we have in the session on cath lab efficiency, we want to show about dealing with large adult hypertensive ductus. So can I have the PowerPoint slides, please? Yeah, 19-year-old male, diagnosed to have PDA in infancy, however lost for follow-up. Is increasingly becoming symptomatic. Recent evaluation showed large PDA with severe pulmonary hypertension. A cath was done outside, which showed a step up of 13%, no step down, and the pulmonary artery pressures were the same. When he came to us last week, his weight was 45 kilogram, high volume collapsing pulses, blood pressure of 150/50. There was a large cardiomegaly. There was a systolic murmur in the left upper sternal border with a loud P2. The heart was looking larger with still plethoric lung fields. ECG shows the LV pulses. Echocardiogram showed clearly, next slide. The echocardiogram clearly showed LA, LV dilatation. There was some amount of non-compaction of the left ventricle. Can you click on that first movie also? Yeah. So there was some milder degree of non-compaction of the left ventricle. However, the ventricular systolic contractility was normal. There was severe pulmonary hypertension by the mild TR jet. Next slide. This is the ductus shown by a ductal view, high parasternal view. We can appreciate a significant left-right shunt, a large PDA. Next. And when we froze the frame and we measured, the PDA measured about 16 millimeter. The frozen frame is seen on the right side, and the continuous color flow is seen on the left side. It's a large 16 millimeter PDA by echocardiography with significant left-right shunt, no lower limb desaturation, dilated LALV. So how do we close it? The question is, we did not do a QP QS because the fallacies of how to sample this ductus, how to sample the exact pulmonary blood flow. So we did not go for oximetry. We did a pressure. Show the hemodynamics live. So show the hemodynamics. So this is the aortic and pulmonary artery pressures. There is a diastolic equalization, and systolic pressure in the aorta is 124, and systolic pressure in the pulmonary artery is 110. Dr. Samir and others, now how will you go next?
So very nice. So this is, we have a few people on the panel. We have Dr. Sulman Labega as well as Dr. Jesse Esch. Jesse is one of our very renowned pediatric cardiologists. Jesse, I'm going to let you do the first honors of saying how would you approach this patient with a very large, significant size PDA and very significant pulmonary hypertension.
So it seems like we need to get a little better understanding of the pulmonary hemodynamics. Can you tell me, I apologize if I missed it, was there a saturation step up from the SVC to the pulmonary arteries?
There was 13% step up from the SVC to pulmonary artery in the previous catheterization that was done about 1 month ago. We did not do one today because,
and how about?
Because we cannot accurately assess the final mixed pulmonary artery saturation. The ductus may be streaming to the right, may be streaming to the left, but in the previous catheterization, the superior vena cava to distal pulmonary artery step up was 13% with no step down.
And how about any change in saturation from the ascending versus the descending aorta?
I told there is no step down. There is no change in the saturation. The PO2 and the partial pressures and the saturations were absolutely the same between ascending and descending aorta. There is no doubt about, there is no right to left shunt at all. It's
sure. So based, one moment, Dimar, so final thing from you, Jesse. Based on this information, what would you do? Let's have you commit to...
Sure. So I would actually, I would remeasure the saturations. I would probably perform acute vasodilator testing to see if the left-right flow increases under those settings. And then I would probably test occlude the PDA before committing to closure.
Great. Dietmar?
Yeah, Shiva, hi.
Hi.
Again. I follow you. You
Okay.
were so angry in the morning. So, did you perform an angiography that you have measured the duct already? So
We
you
will-
measured it,
I
you have.
I will give you the ductal angiogram, but what are the problems that we anticipate in a very large ductus? The pictures are not going to be good. Show the aortogram. I'll
So
show that.
you have to do in any case an sizing of the duct. Then when you size it, do you measure the pulmonary pressure and the diastolic pressure would go down? Then you would close it, or would it go up to avoid it, or would you reduce maybe the duct at first?
Okay, now the question that I wanted was, whenever the ductus is extremely large, what is the utility of an aortogram? Like right now in this particular patient, we are giving 25 mLs at 15 ml per second at 1,000 psi pressures, and this is the picture that we get. Sort of faint images. We froze the frame and we recorded. It's coming to about 15 millimeters. So it's very faintly filling.
Right shunt, but you have left right shunt. This is important.
Yes.
It's a smooth one, but you have one.
Okay.
But do you size now the duct or not?
Since this session is on cath lab efficiency, I wanted to just show how this particular procedure should be done. Basically, we need to occlude the distal part of aorta. Now, the same, if you carefully look at this particular image, I have a Ty-Shak balloon that is floating in the descending thoracic aorta. Can you see the dots there? So,
Yes.
yeah, so now what I'm going to do, the next picture, get ready for the next angiogram. I am now inflating the balloon in the descending aorta, and now I'm going to give a balloon, relax, balloon occlusion angiography. Ready for the angio?
Okay, very nice.
In spite of the occlusion, can you remeasure this one? Freeze it and remeasure.
Tell us quickly what balloon you use.
It's a Ty-Shak balloon 22. Samir, I will tell you why I took that balloon, because the same balloon I am now going to do test occlusion. So
very good.
Now come to AP view. One of you measure this ductus in the frozen frame. Get me the thermo wire. Come to AP view. What we are going to do now is, just give a second, they will measure it. Yeah, it's a 5 French. Okay.
So red is arterial pressure and PA pressure is in blue, yeah?
The PA and aortic pressures were almost the same. Aorta was about 10 millimeters. Go. You freeze the frame when the ductus is best seen. See, this is the difficulties of doing ductus angiogram whenever the ductus is too. Now freeze it. Go back. Yeah. Okay. Okay. Now start the measurement. Yeah. No, it's much below. Yeah. Starting from there, go up to the horizontal. No, go up further. Go up further. Go straight up further. Up. Yeah. No, just little below.
Who else is doing
it is
PDA interventions in the audience? Raise your hand. Perfect. Who is this up front?
Freeze it.
Aha.
Enough.
Let's see.
Okay.
So from your standpoint, what would you're just walking in?
Get the
Jesse, you want to summarize what we've got so far and where we're at?
Sure, we've got a teenager here with a large unrestricted PDA
this one snare
that
inside.
appears to be all left to right, but we're concerned that the patient's pulmonary vascular resistance is abnormally high. It's hard to image the duct because there's so much flow through it. And so we're at a point of trying to get ready to do some balloon sizing and also simultaneously measure the PA pressure with the duct occluded to help guide our therapeutic decision making.
What are your thoughts? Balloon sizing, not balloon sizing? How would you approach this?
Yeah, I think you see some monstrous ducts in the Far East and Asia, and I think balloon sizing is a good idea. You may not get an immediate drop in PA pressure. And I think what's important is the diastolic pressure in the PA. Is that much different from the diastolic in the aorta?
It's identical. The pressure
Well,
tracing
that is
exactly
worrying, yeah.
overlap.
And is the saturation in the arm and the leg the same?
Yes.
Saturation in the arm and the leg are the same. Go back to lateral view.
Yeah. I think if the diastolic pressure in the PA is equal to systemic, that is certainly very worrying.
It is, Dr. Joe, the aortic pressure was 10 less than the pulmonary artery in systolic. In diastolic, they were the same. So now,
So
one of the
made
problems,
a rail.
one of the problems that comes up when we are inflating the balloon across the pulmonary, like ductus, is that the balloon tends to move repeatedly towards the pulmonary artery, and it is very difficult to get a strict like fixation of the balloon. So now what we are trying to do is another clamps. So I am putting two sheets. One is the 6 French, the same sheet that originally was giving us the vascular access for the arteriogram. It's a long 6 sheet, and on the right side we have the pulmonary artery sheath. So now we are going to keep the ductus in the middle, the balloon in the middle, and now we are going to inflate the balloon. So the hemodynamic screen, and yeah, I think it's already there. Now what we are doing is we are going to be inflating this balloon and partially, Sandeep, you give a pull on the balloon, like keep a pull. Okay. So now I'm allowing the balloon to, yeah, little bit more I will try to come out. Little bit more I will try to come out.
Are you trying to get it a little more on the aortic side?
Yeah, I'm actually trying to get it a little bit more into the aortic side. Correct. Hold it. Sandeep, if you give a slight pull on the balloon, when the balloon tends to drift towards the PA, give a gentle pull. Okay, now I need to have PA pressures being recorded. Aortic pressure should be line. Check your PA pressures. Why one line is not showing? Okay, so now that means the balloon is occluding. Now it's coming. Fine. Give a gentle pull. Gentle pull more. Gentle pull more. Relax. Little bit more pull. Little bit more pull. Okay. Little bit more pull. Okay. No, I want it more like this. Okay. Yeah, PA pressure will come. The moment I get it in the middle, then I will fix it. Okay. So now you can appreciate that there is a slight bradycardia. Okay. Now this you should not leave your hands. Okay. Now again I'll do that. You should keep your hands there itself. Pull. Okay. You'll hold it. Okay. Don't take your hands out. Little bit more pull. Little bit more. Relax, relax.
Tell us as you're doing this, what will you be looking for?
I'm showing the hemodynamics on your small screen. Can you see that also?
You can see that.
Yeah. So practically, basically, I'm trying to get the middle of the balloon on the middle of the balloon on the ductus. You are giving a small pull, Sandeep. You have to continuously keep pulling. Not that one, not the wire. I want you to.
Shiva, can I ask you?
Yes.
Or are you in stress? You are never in stress.
Dietmar, maybe we let Shiva keep working to get the balloon in the right place. I'll just ask Gareth his thoughts. Gareth, tell us what sort of cutoffs would you use for balloon sizing and the pressure changes to decide to intervene on this?
Hold this also.
Gosh, I don't know. And to be honest, I walked in late, Samir, so I'm not even sure the baseline hemodynamics work because I come into the case late, so I probably shouldn't comment.
Okay.
Apologies.
So, Jesse, what about, or Deepa, how about you? What?
Yeah,
tell us
thank
what
you
are
very
your
much.
cutoffs?
Because Shiva, you have measured the duct now. You can use a device, and I would use a ventricular septum device with a coronary stent delivered together up, and then you have reduced the duct, but you have, in case that you need reverse pod shunt physiology, still an option. But you cannot let the duct in such huge size. I guess that would be an option.
How big of a stent do you want, and how much of a hole do you
Yeah,
want?
dependent on the size and the length of the sheath. So maybe you need so the duct is minimum 25 long or 30 millimeter long. So you can use maybe in 20. The device is 20 millimeter maybe if it is expanded, and then use 25 millimeter stent or in this range. On 5 millimeter or 4 or 5 millimeter diameter. So you can advance both together through the big sheath.
What pressure difference would make you say, no, I should not close this?
No, in any
Close
case, you need to close it because the duct is too big, but you have the option for pod shunt physiology afterwards when you have a reduced duct, let me say, a communication. But you have a chance for treating them with pulmonary specific drugs afterwards. Now, if the drugs are working, then you have shunt, and if the drugs are not working, then you don't. Then the shunt becomes right to left. Then it's too big.
There it goes. It looks like you've occluded it, and
Yes.
it looks like you've dropped to less than half systemic on your PA pressure.
Correct. Correct. Now,
If it is correct.
Now what I'm going to do will be, I'm actually going to give an angiogram on the side arm of the sheath to check whether I have completely occluded or still I am allowing a residual flow. So my large sheath that I have kept just distal to the PA, just distal to the balloon in the descending aorta, is going to tell me I'm still having a small amount of flow. Can you see that? Just keep, see there is a still, this is still not a complete occlusion. This is still a little subacute, a suboptimal occlusion. Can you see the flow into the PA? Freeze it and show. Come back. Can you see the PA filling? Just run it now.
Yes, there's some opacification in the PA.
Pulmonary artery, correct. So, but with this sort of occlusion, there is a separation of the pulmonary artery and PA. Now measure the waist. I take the balloon length as 3 centimeters and measure the waist. Okay. So now what we are going to do next will be, I'm going to advance this sheath as I am deflating the balloon into the descending.
You know.
Leave it.
Okay, so you brought the venous sheath down to the descending aorta.
Descending aorta. Leave it, sister. Yeah. So now we are going to take out the circuit. So can you measure the waist of the balloon? Moved now. The sheath is in the descending aorta. Relax. And we are going to take away the entire circuit. So now, what sort of device? You saw the separation, Dr. Dietmar. So there
Let's
was.
see the measurement. What was the measurement?
Yeah,
that you said?
can you get the measurement? Yeah, measure now. Yeah, that is actually, if it goes straight, it is an arc. No, not that way. That cannot work.
We cannot see the measurement on our screen.
Yeah, basically it is done in another computer. Yeah, it's okay. Now accept it as 30 and then give a measurement.
So Jesse, tell us on this here, where would you measure from where to where? Exactly on the screen. How would you do it?
Well, we have to decide what diameter device we want, and we also have to decide what length we want. So this picture helps us mostly to decide what diameter of the device we want. And there we're going to be looking, measuring from sort of the bottom of that unfolding on the bottom curvature of the balloon.
Come below that, come below that.
I think you also need to measure the bigger size of the balloon, because this balloon is not fully inflated. And even if you're going to put it where the indentation
take the
is,
balloon's diameter also in the pulmonary artery.
device.
So you have
Around 17.5, and the
Yeah.
balloon was 21.6 roughly. It's a 22 millimeter balloon. So we have roughly around 17.5 to 18 millimeter. So
Samir,
so it's a 8.
Shiva,
It's a,
Shiva, can I ask it?
yes.
Can I
hold
ask-
on, Shiva. Let Gareth want to ask you a question, and then you can tell us what size you're going to choose.
So just on what Joe just said about the size, I think this is obviously a long duct. Therefore, the waist of the device is also going to be stretched, as well as the fact that you probably want some extra security by oversizing it compared to the waist. And I'm just concerned that if you base your size on the waist,
18
you'll
must be
undersize it, because the device is going to be stretched out a bit as well, because it's going to be pulled along the length of the duct.
So make a decision. What device are you going to use based
I
on
would
this?
go big. I would put at least 20 millimeters muscular VSD. I think Joe was suggesting maybe a post-infarct VSD to get more waist length.
Yeah, I think the muscular ones go to 18. So if you're going to go above that, use the post-implant VSD devices. But I would measure the aorta, the balloon proximal to the so-called narrowing, and use that as my diameter. I will not oversize because you've got your rims, but I wouldn't use this smallest diameter. I would use the bigger diameter. And post-infarct and fenestrated, as Deep Marchand suggested.
So
Shiva, you work.
Joe,
This-
I heard your view. So it should be a muscular device, right?
That's what Joe's saying.
Yeah, I mean, what is the diameter of the balloon just proximal to the indentation?
It's a 22 millimeter tie shack balloon that we
Is that a
inflated.
diagonal diameter or is that a vertical diameter?
The vertical diameter is 21.6.
Right, I would go for a 22 post-infarct VSD device.
Okay. If you don't have an access to 22 post-infarct VSD device, I wanted to show one particular type of VSD device that the Lepu Medicals makes, which is called as the MemoPart VSD device. Can you show the picture?
I suppose an alternative would be to use an ASD device or something similar.
Okay.
What's that? What device is that?
Oh, this is a memo. I'll show you the. Can you show the box? So this is Lepu Medicals. It is one of the Chinese companies, and they make a device which is called as MemoPart devices. The advantage of this particular device is that they have a lot of customization here. Now come to the device. I'll show you here. This is a 18 millimeter device. However, there are two discs on either side. Since in this particular case our aortic pressure is higher and the PA pressure is lower, this aortic disc is marginally bigger than the PA. I'll try to show you. Let me see.
Yeah, we see it.
Okay, so this is 24 on the. This is 28 on the LV side, that is aortic side, and 24 on the PA side. So the central waist of the is 18 only. However, the 18 becomes 28. So there is a 5 millimeter flange on the LV side and 3 millimeter flange on the RV side.
Yeah, it looks attractive. I don't know how soft it is, but if that's the biggest you have, then you should do that and deliver it from the venous side, as you suggest.
Okay.
Okay, so
Now,
what about,
like having it is like almost as stiff as an Amplatz or muscular VSD device. It is not soft like a post-MI VSD device. The post-MI VSD device is made up of thinner nitinol wires, and so this is a little bit softer. However, this is more like a 18 millimeter muscular Amplatzer VSD device. However, the advantage is, while an Amplatzer 18 will have a 4 millimeter flange on either side, this is 5 and 3. It's higher on the aortic side and lower on the PA side. So now I am going to load it under water, and
Siva,
yes,
in terms of morphology of your duct, what
Yes.
was the length and shape?
the shape was conical. It was a type A PDA. The shape was like a type A
And the
PDA.
length?
Yes.
And the length?
Length was almost about a centimeter. The diameter on the echocardiogram was 6. Occlusion is almost 18.
Dietmar, there's no penetration. What do you think?
Yeah, no, it is. It's a hemodynamics mentioned me that it's not necessary to have now and Potchan and physiology later on. I think this is a good idea to use this device. And in addition, I have only done it once time in a Amplatzer muscular VSD, but this seems better. If you need later on, maybe the patient will develop in suprasystemic pressure in 5-6 years or whatever in the follow-up, then you can perforate this device again and make it stand then in as a Potchan. That I want to consider in addition. So,
Get a 6
but
French
now,
pigtail. 6 pigtail.
but now you can.
So now we have put in
Yes.
the device. Can you fluorostore and show the device? Fluorostore.
Shiva,
Yes.
Is this a pulmonary pressure now when the device is in?
Yes. Pulmonary artery pressure is now about 75. The aortic pressure
Not
is
good.
180.
I don't like a mean pressure, but the diastolic pressure is great. It's 49 to 83. That means the resistance is 2-to-1.
Okay. Now I have either side of the one is facing the aortic side and another is facing PA side, and these are the pressure hemodynamics now.
Looks super good, but is the device too far in the pulmonary artery, or you have to be aware? I don't know exactly. Looks from here.
I will show you an angiography. I want a 20 cc syringe. Pictal is ready. So now I am going to give one angiography now. The PA pressures are coming nicely low. We are going to give an angio.
Looks super.
Yep, very good. What do you think of that residual flow? This is just from the tilting of the device, right? Not from.
It's through the fabric of the device, I think. See, now this is the PA and aortic pressure now. The pulmonary pressure is 58 by 30. Aorta is 160 by 97. There is a mild bradycardia caused by the acute closure of the PDA. And Dr. Bhushan, one of my colleagues, is going to show an echocardiography because there may be an acute left ventricular afterload mismatch. There may be an LV dysfunction. Come closer. Help him out. Come to APVO.
You could, I suppose, make the argument that the fact that some residual flow at the moment might allow some, I don't know whether I believe this, might allow some time for the physiology
put
to
the flow.
use to, I'm not sure whether
Apical
that's legitimate or
chamber.
not.
Give him Milrinone because he had
echo big.
a high afterload now by closing the duct, I guess.
So echo big.
Yes.
Yeah, you are able to see that there is some degree of LV dysfunction. However, the blood pressure, systolic blood pressure is also quite high. So we will try to trim it down a little bit with pharmacological agents. He's looking comfortable. You're okay? So you can appreciate the acute afterload mismatch with left ventricular dysfunction. Show a little better LV apical view. Show the entire LV, all the segments. Can you appreciate that, Dr. Dietmar? Samir?
Yes, we see it.
Yes.
Yeah, so show the ductal
That is
flow.
acute. That means, in other words, the duct needs to be closed, but the left ventricle have to be adapted because you have
Go to
a
ductal
high
view.
diastolic dysfunction. But this is mostly transient.
So now we are trying to show you the residual flow through the ductus. short axis.
Jesse, what else do you look for in echo aside from the LV dysfunction and what the ductal view is?
I have to be honest, I don't usually do intraprocedural echo for PDA closure.
Shiva, he is saying he is more efficient than you.
I agree.
Nobody's more efficient than a cath lab in India.
Okay. So now this is
What
the
about you?
this
Are
is the
you doing echo or
suprasternal
no?
view. Okay, put the color. So that is the so this is the aortic arch and the aortic end of the disc. Now I am going to show the pulmonary end of the disc.
That looks perfect. Can you measure the mitral inflow in the, with a PV,
Do that.
PW too?
I will do that. Now color. Actually, there is no continuous flow into the PA as of now.
Samir,
Aorta.
I would say that
Yeah.
we would only do echo in special circumstances, of which
Okay.
this is one.
Color the
and
mitral inflow.
premature ducts as well.
Mitral
so,
inflow.
but not for routine ones.
Pulse wave, mitral inflow.
But yes. Yeah, it's a little, no, it's
Special circumstance includes live cases.
a little bit restricted, not so much.
Not bad.
So explain
Okay.
Deepa and Shiva, or actually Shiva, explain what you're seeing on the mitral inflow for
Oh,
audience.
okay. Basically,
What
you
is good, what is not good.
okay. You
What-
if you have a
for example,
if you have a significant
So-
restrictive pattern with a very sharp E deceleration, then you are concerned. But this looks okay.
Exact.
This looks like the left ventricular end diastolic pressure may not be too high. So now, right now, can we release? Go to lateral view.
Anybody that thinks we should not release.
So
Nobody is raising their hand.
Actually,
Everybody
the
is
pulmonary artery
pleased
pressure
with-
is quite low now. It's comfortably low. There is a lot of separation. Show the hemodynamics big. Hemodynamics big.
these are the Indian and Asian genes, they have quite different from the Western countries.
Why is your arterial diastolic so high?
Which diastolic? Aortic diastolic is high because of acute closure of the PDA and sudden increase in the
Yes.
systemic afterload. Yes, we are. Now, previously, the left ventricle was pumping both into the PA and into the aorta, but now it is pumping
Yes.
only into one vessel. The
I
end,
would give him mineral for 24 hours.
I will give just a captopril, and because he is looking comfortable to me, he's not in any sort of distress. The PA pressure is quite low, so you want a last PA angiogram. Come. So one last PA angiogram, and we are.
Which view are you going to use? I generally use the steep caudal, but what projection are you planning to do?
You are talking about the aortogram, Dr. Joe?
No, PA angio.
Oh, you want a PA angiogram?
Well, I thought that's what you're doing, sorry.
Oh no, I was taking a repeat aortogram just to see whether the residual flows have completely gone off, and second thing is whether the device is very, very secure or not. PA angiogram, the pulmonary arteries were massively dilated, and I think there is no concern about PA, any of the branch PAs being compromised. But if you want, I can do a PA angiogram also.
No, I misunderstood you. I thought you were doing a PA angiogram
How much
because
you are
you've
giving?
already done an aortogram.
Make it
and
30
little
at
residual
80,
flow,
30 at 80.
no consequence.
Okay.
And even if it is there, you're not going to do anything about it.
Yeah. So actually, this boy had a pulmonary arteries measuring, each one was 25 millimeters. So there is no concern, unlike in a small infant, about PA narrowing. So right now we are. Looks good to me. Most of the PA.
Great job.
So the difference between this particular device, even though I chose 18 millimeter was my waist on the balloon, and still I took 18 millimeter. The advantage is that the left ventricular disc or the aortic disc was much larger than what a normal muscular VSD will be. So actually, in one way, I would say this was a very clever thinking on the part of the company to have decided to keep a muscular VSD device, but LV disc is 5 millimeter flange and RV disc is 3 millimeter flange. I think it makes a lot of sense, even in suppose a large muscular VSD, to have a little larger on the LV side and little smaller on the RV side. So I just wanted to show this particular device, and you can, in the fluoroscopy, you can clearly appreciate that the LV disc, the aortic disc, is little larger than the PA disc. So
Siva,
yes,
large PDAs tend to be expansile. Why did you not consider oversizing the device in this case? I mean, this has worked out perfectly, but I'm just wondering.
PDA device also could have been a chance. We could have chosen a little larger sized PDA. I probably would have chosen, if it was available, something like 26, 24 PDA device. However, the maximum size that is available with the Memopart company is only 22 by 20, which will not give me a zone of comfort. So I went for a muscular VSD device, which is traditionally considered to be a safer device in a hypertensive ductus. However, I wanted the aortic disc to be little larger than the PA disc, and such a customization of the device was feasible with some non-Amplatzer company.
I think with your high pulmonary artery pressure, it's also important to have a disc on the right side.
Exactly.
So that the device doesn't rock.
Yes.
And you get a much better seal.
Exactly. Actually, suppose if I try to close this with a very large duct occluder, still there will be a lot of apprehensions on chances of reverse embolization. However, when we are putting a muscular VSD device, we sort of get a comfort. We are playing in a comfort zone.
Sounds good. Shiva, you have another case after
Yes.
this.
Yeah.
correct?
Yeah. We are
Right, sounds good.
already. My colleague is fully ready. So at any time, whenever you want to come, we are just ready.
Okay. How do you want us to do one talk and then switch back
Yeah.
to you, or do you want us to go direct to you?
No. One talk and come back. We are ready.
Sounds good. Let's go ahead and do that. Congratulations on a great closure of the PDA.